Hello and welcome to Two Peds in a Pod, the paediatric medical education podcast. My name's Ian Lewins. Welcome to the first podcast of 2021 as we welcome back Doctors Damian, Roland and Ali Monroe to discuss the new variant COVID. Enjoy!
Hi there, my name's Damian Roland. I'm a paediatric emergency medicine consultant at the Leicester Royal Infirmary, and I'm here chatting to Dr. Alistair Monroe. Ali, do you want to introduce yourself?
Yeah, hi, I'm Ali Monroe. I'm a clinical research fellow in paediatric infectious diseases at the NIHR Clinical Research Facility in Southampton.
Right then, so we spoke last year, in fact, but probably a month or so ago by the calendar, and we were talking about vaccinations, but about vaccinations for the whole of the COVID population, and then a bit of detail about children. And quite a bit has changed since then because we're now in a complete lockdown and schools have closed. So just in terms of summary, what happened in the last month or so that has changed the landscape so rapidly?
Yeah, a lot's changed, doesn't it? It almost feels like a lifetime ago that we last were speaking. I guess we in the UK we had in England we had a national lockdown in November, but schools stayed open, and that followed a pattern that was sort of used in quite a lot of continental Europe at the time, and Ireland and elsewhere, and it was relatively successful because cases started falling, and cases obviously stayed higher in children for a little bit longer, and that's sort of a normal pattern in disease prevalence because the prevalence in children tends to follow behind a couple of weeks what happens in adults. So the rate started falling in adults, and we were waiting for them then to start falling in kids. And when the lockdown was lifted, cases suddenly started exploding and increasing really rapidly, and not just in adults but in children as well at the same time, which was an interesting pattern that we haven't really observed in the past. And what it turned out sort of afterwards was that, people were obviously very surprised about this, and there was this sort of hint of this new variant that started being talked about of the virus.
Take us through the new variant. Actually, what is new about it in terms of its, I suppose, the molecular makeup?
Yeah, so it's got a number of mutations that it's an unusually large number of mutations, essentially, that could possibly affect a number of different things about how it transmits, including potentially affinity for the ACE2 protein. But it's the B117 variant. But essentially, we didn't necessarily have any really strong reasons based on the genetic makeup of the virus or any molecular biology to think that it would be radically different to the old one. But it's been the epidemiology that's indicated that this new virus may behave in a different way to sort of the previously circulating strains in the UK of the SARS-CoV-2 virus. It's mainly been the epidemiological evidence that's led us to believe that it's doing something a bit different.
Okay, so we were facing this situation where after the lockdown, things didn't go as planned. And it took a bit of time, I suppose, for the full realization of that to really become apparent, I suppose, politically rather than scientifically. But a decision is then made to close schools. What should happen now? Like, what are you predicting will happen over the next couple of weeks, months?
Oh no, I don't want to try and predict what's going to happen because it's almost impossible to know. I guess we're in a really precarious position. The decision to close schools, I know, wasn't made lightly, and certainly part of the reason was that there were early concerns voiced that increased transmissibility of this variant was particularly noticeable in children, or that it may disproportionately be more infectious in children than anyone else. Now, that was based on some early evidence that the number of cases in children that was caused by the new variant as a proportion was higher than in adults. Now, actually, as time's gone on, that's evened out quite a lot, and the consensus is really that the reason that was the case was when the variant started sort of taking hold in England, it was in the lockdown. And so at that point, children were mixing significantly more than adults. And so they just happened to be, the group where it was
reservoir.
Yeah, exactly. It was just easy for the virus to take hold, and that's evened out now. And so, as it turns out, the increased transmissibility is probably equally true for all age groups. That's certainly what the evidence suggests, and somewhere between 30 to 70% more transmissible. But basically, the things we were doing before weren't working. So the government obviously tried doing local lockdowns with restrictions for tier 4. We had Christmas where, famously the government had to roll back on a lot of the promises it had made. But even, during the holidays when a lot of the country was in lockdown and schools were closed, cases were still rising. And so it was felt that, regardless of how much schools contribute to transmission, they contribute something. And so if you've still got cases going up, even with schools closed, that opening them will only make it worse. And so I guess they felt they were in a position where they were unable to do that, at least for this term. But as to what will happen now, we really don't know how effective the new restrictions are going to be. Certainly in November, we turned things around by now in most of the country with restrictions that were very similar and with schools open. So it's difficult to know what we'll be able to achieve and how quickly with the new variant, because essentially we're in a position we've not been in before.
And so what are the other things that do you think have been impacted or haven't been impacted? So that listeners may have heard that there was this concern that children's wards were filling up with patients with COVID. And actually the terminology becomes really important here, because it's not children who were ill with COVID. It's more likely, I presume, that it was children who were going to be in hospital anyway who happened to swab positive for SARS-CoV-2.
Yeah, absolutely. So at the moment, there is no evidence at all that the new variant of the virus causes more severe disease. So once you're infected, you don't get any more sick than you did before. What's changed is that given the same amount of exposure, you're more likely to become infected than you were previously. And again, like we said before, there's no evidence that is more true for children than it is for adults. It seems to be equally true for everyone. So certainly, we've seen rates of the virus increase everywhere, to the extent that in some areas of London, it's 1 in 20 people have the virus. So that means that sort of by chance alone, you will have a lot of people in hospital who will test positive, even if the reason they came in was not with the virus.
Do we know how that compares to other kind of epidemics or pandemics? Seasonal influenza, for example. Do we know how many people in the population have it at any given time?
No. Well, if we do know, then I don't know. No, but I've looked for comparable data, and no, I've not been able to find it. But I wouldn't imagine it was anywhere near that high. Although it's probably, we know it will be higher in children than in other age groups. But as an incidental sort of finding, no, I don't think we have that kind of data.
And just while it's kind of on the tip of my tongue, so this impact of having more children who, it might not make them any worse, but more children have it. So what does that tell us about PIMS-TS, the inflammatory condition? I'd have thought that we'd have started seeing a surge in cases already, and I am informed that there are kind of intensive care units and departments are seeing PIMS cases in London and elsewhere, but I'm told it's probably not going to really hit until mid-February.
I guess it's probably never going to look quite the same as it looked before because of the shape of the epidemic curve for children. So we know that cases, obviously when the first wave of the pandemic hit, there was no restrictions in place, and very, very quickly, extremely large numbers of people were infected. So in a very short time period. And then there was a lockdown and schools were closed, and really, it was a quite severe lockdown for people, other than key workers. Everyone was really consigned to their homes for weeks and months. And so, children were not becoming infected at very high rates after that point. So there's a very steep spike in infections in children in particular, and then not many after that. And so that was replicated in the epidemic curve for PIMS. So what we saw was a very sudden surge of cases. And what we've had this time around is very different. We've had a much more gradual incline in cases in all age groups, and in particular, actually, the age group that is most affected by PIMS, which is younger school-age children. They were one of the last cohorts to increase. So children sort of, 7 to 12, that age range is the median age for children with PIMS. And that was the sort of the age group that had an increase in prevalence after most other age groups in this second wave. And then again, it's been sort of a steady, there's not actually been a huge change in prevalence in children since then. So I don't think we'll ever see the big surge that we had before, but it will probably be a more, this would be my prediction based on how it follows the curve, is that it will probably just see a more consistent sort of admission pattern coming in, including over the next few weeks. But the spike that happened just before, I think cases now are not much higher than they were before Christmas. So I don't think we'll see a spike in admissions in the next few weeks. We've not got reason to believe that would be the case at the moment.
And then what's going to be the impact, do you think, of this bigger, more pronounced lockdown than I think maybe some people were expecting before we knew about the variant, on other diseases in children? So RSV appears to have been eradicated, and what was interesting is that it did appear in Western Australia to make a bit of a comeback. I've just got to look up some more data on that. And it's nice to see that published so easily from the Western Australian government. But do we think now that we've gone back into lockdown and this is going to really play out, and then we'll be in summer, that we really will miss RSV completely this year? And what does that mean for next year?
That's quite a difficult question, because I think it will depend on what restrictions are still in place come that time of year, to be honest. I think if we are still, and it's likely that we'll still be having to adhere to some levels of social distancing and mask use and all of that kind of stuff, which seems to have been really effective at preventing, widespread RSV. Well, I mean, preventing almost any RSV at all. So if that's still going on over the summer, then hopefully we'll see still not very much of it. But then I guess if a lot of restrictions are relaxed because the vaccination program's been successful, or because of the seasonality, we have got very low levels of COVID, and who knows what government policy is going to be next week, let alone in a few months' time, then I guess we should. It's something definitely worth bearing in mind over the summer and spring, that we may see a resurgence of RSV. Although hopefully by that time we'll have ample capacity to be able to manage a sudden unexpected bronchiolitis swing on the paediatric wards.
Okay, well, that's reassuring, hopefully. So vaccines. So we know we've got 2 out now in the UK, and that some children's programs have begun. Is there anything new that kind of paediatricians or those involved in child health need to be watching out for, or trying to get involved in?
Yeah, I guess I know that there's plans from several of the pharma companies and Oxford to start trials in children in the coming few weeks and months. And although I think the initial plans are for adolescents 12 plus, that there are also plans for younger children trials as well. So if those studies that are recruiting at your sites, then it's always worth seeing if you can get involved and try and aid recruitment for those, because the quicker that we're able to get those studies done, the sooner that hopefully the vaccine should be available for children. But it will be, it's going to be really interesting to see the results of, the immunogenicity, as well as the side effect profiles in children, because, the disease itself is manifestly so different for children than adults. And we think that part of that is to do with the immune response. So I guess it is quite an interesting field, thinking about how vaccine responses may differ, and then particularly the side effect profiles. I know that it's a pretty reactogenic vaccine. Well, the vaccines that are currently authorised in the UK are all quite reactogenic I don't know if you've had yours, Damian, but I was not feeling 100% the day following my first dose of the vaccine. So, yeah, I think
surprisingly, I have the flu every year, and people kind of say, "Oh, it makes them really unwell." I've never had a problem, but having had the COVID vaccine, I definitely was not right for 24, 36 hours. I mean, nothing major. I mean, clearly you complain about it with man flu and all that, but I got through it like the stoical person I am. But I certainly, it's the first vaccine that I've had in a long while that's made me feel unwell.
Yeah, so it'll be really interesting to see those side effect profiles for kids as well. Yeah.
Okay, so what does I suppose the future now hold? So we've got this lockdown for a couple of, probably at least in a month more. We will start to come out of that at some point this spring, I suppose. We know that children haven't been affected probably in terms of their own illness levels. We'll watch and wait to see about PIMS. We've all expressed concerns the longer schools are closed, the more harm that is done long term for children's mental health, well-being and achievement. What's the earliest you think we can get schools open in terms of the volume of COVID new variant we've got out there at the moment?
Yeah, that's a really good question. And I think a lot of people are thinking about that at the moment. So obviously in England, the government has said that the February half term is the next point where schools might return. I guess given how slow this wave of the pandemic has been, during this lockdown to turn around, I mean, cases are still rising. Whether cases will have, really come down much at all by then is anyone's guess, and I guess there's a real possibility that might not be the case. And then the other consideration is that during it, sort of in London and Kent, during what was an otherwise a complete lockdown, this variant managed to take hold in schools quite quickly, and whether the current infection prevention measures in schools are really effective enough for to prevent widespread transmission at decent levels of community spread. So, we managed to keep schools open for the whole of last term, which is quite impressive given, how much transmission there was in the community. But whether that will be doable in the future, with those same levels of spread, I don't know. And I guess there's got to be some real thought about what we need to be doing if actually schools are not going to be back in session until the summer term, and thinking about what the effects of that are going to be and how we can mitigate against those. A lot of the planning has been very short term so far, and some of that's understandable because things change so quickly. But I think we can see now there is not a rapid turnaround from this wave of the pandemic. It's not suddenly falling like a stone out of the sky. And so I think we need to be ready for the impacts if schools are really not going to be back for another few months. And I think there's a lot to think about there, and there's potentially a lot that could be done.
Okay, excellent. Thank you very much for that. I'll probably draw things to a close there. Is there anything else that you're particularly looking forward to in terms of data? Are there any big studies or anything else that people should be aware of?
I think it's trying to see the impact of the vaccines is going to be the really important thing. So I'm looking at Israel at the moment. So they've had probably the most successful national vaccine campaign, and have vaccinated a huge proportion of their elderly and most vulnerable populations, and are basically waiting to, it's been enough weeks now that they're expecting to see rates decline purely on the basis of vaccination alone. So I think it will be really interesting to see that data, and then thinking about how that will influence hospitalizations and sickness in the UK, because we're doing a decent job at the moment. We're getting pretty good vaccination numbers, especially compared to the rest of Europe. So that will be some of the data I'm most looking forward to seeing. So it's particularly the optimist inside me.
Excellent. Well, thank you very much for your time as always, Ali. And I'm sure we will speak again, maybe in a month or so, just to see, hopefully, that we're really over the peak of things now, and looking forward to a brighter future. Thanks
Great.
again.
Thanks, Damian.
Thanks, guys. And thank you for taking the time to download this episode. If you enjoy our podcasts, please tell your friends and colleagues and subscribe on iTunes, Spotify, Amazon Music, and Google Podcasts. See you soon.